My name is Scarlett Lawson, and I'm a registered nurse, and I've obtained an associate's degree in nursing. I'm on the road to finishing my coursework in the RN to BSN program here at the University of Kentucky. I've been a registered nurse for approximately 15 months, and I've obtained a great amount of knowledge from not only my coursework, but my experience as an RN. I'm looking forward to finishing up my soon-to-be bachelor's degree in nursing, like most of my classmates are as well. Now, in the capstone course I'm currently taking in the nursing program, I was required to obtain practicum hours to collect data and form a plan with meeting objectives for my evidence-based capstone project. My learning goal was for a better understanding of nurse-patient staffing ratios in large hospitals and their impact related to nursing care and patient safety. I chose to do my practicum at a university hospital consisting of several medical surgical floors, telemetry floors, and an ICU. I wanted to have a good understanding of not only one focused area of nurse-patient ratios, but a general overall understanding of the such. The learning objectives that I set for my evidence-based project were as follows: to explain the impact of staff-patient ratios, explain the financial aspects of the staff-patient ratios, and lastly, explain the reasons for evidence-based practice concerning staffing ratios in nursing. I accomplished the learning objectives by researching several evidence-based articles, scholarly journal articles, and up-to-date data on nursing ratios in similar sized hospitals in the United States compared to my practicum site. I spoke to my preceptor about the staffing ratio policy that was set at the university hospital, and I compared them to similarly sized hospitals in the U.S. I also researched journal articles about the financial aspects of nursing staff ratios. And lastly, I researched into the rationales as to why these nursing staff ratios were set and what possible patient safety issues arose from the less than desired nursing staff presence. The handbook for my practicum site contained useful information about staffing ratios for nurses. Staffing of nurses to patient ratios were different per unit depending on the level of care of the patient. Nurses can be downstaffed or called in depending on the acuity of patients at my practicum site, and they differed each day that I was there. The Society for Health Systems concludes that the best practice guideline for optimal staffing model should include nursing leaders, staff, and administrators, as well as be objective, tested, and repeatable to be a valid method used for staffing levels. The optimal staffing model should also match the clinical staffing based on their age, acuity, and ability to perform activities of daily living. Staffing of nurses should also fluctuate day and night per shift based on the census and patient care requirements. The American Nurses Association states that patient safety and quality of care is greatly impacted by safe staffing. One analysis shows that when a registered nurse staffing is increased, significant improvements in patient mortality following a surgical or medical complication occurs. Further data in 2013 revealed that higher staffing of nurses leads to a shorter length of stay of the patient and a decrease in the number of sepsis, deep vein thrombosis, and pulmonary embolism cases occur. The American Nurses Association goes on to say that a higher number of nurses in a given unit in the hospital is associated with higher survival rates among severely ill patients. The rationale for the patient improvement is based on nurses having the quality time to spend with their critically ill patients and are more likely to detect deteriorations earlier. A study conducted by McHugh and Ma in 2013, it showed that hospitals that support a positive work environment and a manageable patient load, they lead to significantly better patient outcomes. When nurses have patient-to-nurse ratios of 1 to 4.95 or less, additional time for patient teaching and preparation for the transition home can occur more easily. The heart failure readmission rate is reduced by 7%, the acute myocardial infarctions by 6%, and pneumonia readmissions by 10% when there is a lower nurse-patient ratio. The Journal of Nursing Administration found that an increase in registered nursing staffing levels has resulted in a reduction of 5.7% in patient days and a decrease in the avoidable never events such as hospital-acquired pressure ulcers and inpatient falls. Now, the subject of cost comes to mind now. The idea of having more staffing for registered nurses sounds like hospitals would be paying more money for staffing and be losing money in the end. Wrong. Now, according to the Agency for Healthcare Research and Quality, the reduction of pressure ulcers, urinary tract infections, patient falls, and injuries, for example, lead the hospitals to eat the whopping estimated $8.5 billion a year to these contributed to. Hospital-acquired pneumonia is contributed to lower nurse-to-patient ratios, and it costs the hospitals $22,000 to $28,000 annually. So it makes sense to say that the significant decrease in medication errors occurs when there is an increase in the number of registered nurses on shift. A study performed by Frith and Anderson, Singh and Fong showed that for every 20% decrease in staffing levels below the minimum results in an 18% increase in medication errors. Now, on the other hand, patient safety is not the sole issue at hand concerning less than desired patient-nurse ratios. The Department for Professional Employees found that understaffing not only impacts patients, but nurses' health and desires as well, and that's very important. Musculoskeletal and cardiovascular disorders such as cardiovascular disease, hypertension, depression, neck and back, shoulder injuries as well occur due to inadequate staffing. Chronic fatigue, exhaustion, irritability, insomnia, back pain, headache, and weight gain are symptoms that describe a well-known term that nurses can experience known as burnout. Each patient over 4 per nurse is associated with a 23% risk of increased burnout and a 15% decrease in job satisfaction. During my clinical rotation, my practicum site was closely linked to similarly sized hospitals around. Staffing ratios on 3 out of 4 floors were 4 patients to 1 registered nurse. The floors were similarly sized based on medical surgical patients. Now, the intensive care unit consisted of a ratio of 2 patients per 1 registered nurse. Because the level of care was more intensive, and as opposed to a medical surgical floor. The progressive level of care patients consisted of 3 patients to 1 nurse. The evidence-based research that I found that was consistent with what I observed at my practicum site concerning staff ratios. I feel as though there is always a need for change in any workforce out there in today's world with ever-evolving healthcare. We as leaders should always make changes based on evidence-based practice in a workforce environment. There's always room for improvements, from nurses to doctors, from patients to healthcare teams. One must appreciate the fact of nursing staff placing their personal input into the ratio of staffing, along with administration and nursing leaders. It seems to be a set ratio based on leaders and administration, and little input placed on staff nursing experience at my practicum site. I like the fact that my practicum site fluctuates between patient acuity and fluctuations in census, but could focus on critiquing staffing ratios based more on patient care requirements. I feel as though the practicum site looks at a patient as what his or her status is and does not consider the time that it actually takes to care for the patient. So for example, you have two patients that are considered progressive status. One patient requires a great amount of time to care for his or her stage 4 pressure wounds, and they also have a low hemoglobin count. That leads the nurse to administer, by the doctor's orders, of 2 units of packed red blood cells in her shift. Also not forgetting all of the other aspects of care in an allotted shift. The other progressive patient is stable, requiring some added replacements of potassium and magnesium, IV, among other patient care tasks in that allotted shift. The first progressive status patient requires additional nurse-patient care than what the later patient does. Now, these patient care requirements must be considered to make a nurse's patient care load safer and more manageable. Not only is it important to consider the numbers, but patient aspects of care when considering the nursing staffing ratios. These considerations should be considered. When I look at my personal experience at my practicum, I've realized that I am more aware of how nursing staffing ratios work and why they are set the way they are. I'm finding myself already sharing with my coworkers the experience and research that I have done to lighten the change of viewing the staff. I feel as though most nurses are biased when it comes to staffing because they feel as though that ones in management do not understand the aspects of nursing and the patient loads that they carry on a daily basis. Nurses feel overwhelmed and understaffed at times, and this is partly due to being short-staffed at times. But evidence-based practice shows that safer staffing and research has been and will continue to be conducted to find adequate numbers to support nursing staffing ratios. Nurses must voice their own opinions on the subject of safe staffing ratios, and they should conduct their own research and share the ideas with their nurse managers in hopes of addressing less inadequate staffing so something can actually be done sooner than later. In every aspect of nursing, patient safety and quality of care are number one and will continue to be adequate and excel with a solid plan addressing nurse-patient staffing ratios. These are the references that I've used for my capstone project. It was my pleasure sharing my practicum experience with you today. I hope that you will take some of the material that I have presented to you and make it personal in your plan to improve patient safety and quality of care. Have a great day.